Navi Mumbai, and today we are going to conduct a instruction course on surface ablations, a rebirth. We all know that PRK was the original procedure that started refractive surgery, laser-based refractive surgery. However, it lost its appeal over the course of years, and LASIK became the main treatment modality. However, in the last few years, the surface ablations have made a sort of a comeback. If you look at the data in USA, it was around 5 years ago, only 5% people did surface ablations, but today almost 25% doctors are doing surface ablations. While in Europe, it's even more, around 70 to 75%, apart from UK, are more into surface ablations. And even in our country, many new cornea fellows coming out are preferring surface ablations. So something has changed, something new has come. And the main thing is that we have gone from broad beam lasers to flying spot lasers, and that has reduced the various side effects of surface ablations. So we'll speak about it in the coming few talks. And we have our first speaker, Dr. Sunil Morekar, who is a senior surgeon, ophthalmic surgeon, oculoplasty, glaucoma, and has got a lot of interest and work done in corneal neurotization and corneal nerve supply. So he's going to speak to you today about surface ablations, how they are safer than the lamellar procedures. Dr. Sunil Morekar.
Can you all hear me? So I'll keep my mask on. From here. Can you all hear me? Yeah, this is better. Yeah. No issue, no issue, no issues. Thank you. At the onset, I would like to thank AIOS, the scientific committee, and more thanks to Harshadan Ghurpade. So though I'm talking about it, I've kept his name as first, for the simple reason that the picture demonstrates my life. So that's Sunil Morekar, who goes below the surface and gets into trouble many times. And that's Harshadan Ghurpade, who skims on the top and flies and is flying high without having any problem. So I think my first slide is revealing what I'm going to talk about. So conflict of interest, none. The objectives, the participants at the end of the presentations will be able to state which two groups of patients can undergo surface ablation safely when LASIK is contraindicated. State the time duration of recovery of best corrected acuity of both procedures, how many years it takes for the subcorneal nerves to recover after both procedures, and a couple of other things as well. But I have kept the objectives few. So in terms of safety, let's look at the indication safety. So surface ablation allows the surgeon to treat patients with thin corneas and higher errors who might be contraindicated for LASIK. So these are the two references I was speaking about. And the AAO refractive management intervention preferred practice panel, they talk about myopia less than 14 for surface ablations and up to 12 for LASIK, and hyperopia up to 5 with 3 diopters, and mixed astigmatism can also probably be corrected by surface ablations. So what happens to the best corrected visual acuity when you look at surface ablations versus LASIK? So myopia, when it is corrected with PRK, shows better acuity, and PRK is better in terms of efficacy than LASIK for myopia after 4 years. So look at that graph, the time course of the average and 95% intervals, confidence intervals of best corrected visual acuity in the laser in situ group, which is a closed square. So these are the closed squares versus the PRK, that is the open square circle, right? So what you see here in the graph is initially you have a better correction, and then in LASIK, in PRK the initial correction is not so great, but at 4 years and 10 years also sometimes, you will see that the PRK does better. The predictability studies. What is the predictability? I mean, you think that you're going to get a minus 0.5 or a plus 0.5, or you have aimed for a particular correction. So the predictability of refraction and the percentage of the target refraction. So the percentage of patients who reach the target refraction of plus or minus 0.5 diopters in a 12-month follow-up are better and comparable in trans PRK for both myopia and high myopic groups. So there are 4 studies which have done this. So when you do a review, you realize that many studies are talking about PRK being better in terms of predictability. So you aimed for a 0.5, you get 0.5. You don't get surprises. Then comes my favorite topic, the recovery of the subcorneal subbasal nerve density after PRK and LASIK. So we do a lot of corneal re-innovation surgery. We take the sural nerve and connect it to the supraorbital, supratrochlear and into the cornea. And there are many cases in which we have a corneal opacity and you return the corneal innervation and you realize that the opacity sometimes reduces in size. Corneal grafts sometimes don't do well if the corneal innervation is not good. So the stemness of the stem cells in the cornea are dependent on corneal innervation. So if the corneal innervation is not good, the stem cells will simply not function like a stem cell. So what happens to corneal subbasal nerve density? It does not recover to near preoperative densities until 5 years when it comes to LASIK as compared to 2 years after PRK. So that's the graph which shows up to 5 years. That's PRK and this is LASIK. So you see the difference between the two. Corneal sensitivity, because the nerves are less. So we do an analysis of the nerves in many of our patients, confocal and with many other devices, and we realize that the nerves are less, especially a lot of patients have already undergone procedures. Some of them come to me with diabetic corneal sensations reduction, diabetic neurokeratopathy. Some diabetics who have undergone a LASIK or a PRK in one eye will have a lesser density in that eye compared to the other eye. So uniocular myopes who are diabetic. So then people come and tell me this is because of diabetes, this is diabetic corneal nerve loss. But no, diabetics, it's worse when you have done a LASIK compared to the diabetic in which you've done the PRK, especially in uniocular myopes when you see that the other eye has not been operated. So it's not diabetes, it's got to do with something. So I am already a little, it's like being hit by COVID. I'm already a little weak and you hit me with COVID, I will be worse. I'm healthy, you hit me with COVID, nothing may happen. I'm healthy, you hit me with LASIK, nothing will happen. I'm not healthy, diabetic, you hit me with LASIK, I might have a problem. Might, not will. So then the other things, the nerve fiber density, the branch density. So you don't look just at the nerves, you look at the nerve fiber density, how many nerves per square centimeters or per square millimeters, branch density and fiber length. What is the length of the fiber? Does it go right up to the center? So some nerves they regenerate and they just fall short of the center, whereas in PRK they go right up to the center. So looking at the nerve density, you look at nerve fiber density, LASIK, pre-op, these are comparable values. So there are times when people tell me many of the data which I look at, people tell me what is a post-op comparison, but have you compared it pre-op? The pre-op demographics and the statistics should be comparable. You didn't start off with a group which was already very bad, right? So you look at the nerve fiber density, pre-LASIK versus LASIK, and the p-value is significant. Post-op 1 month, 3 months, 6 months, nerve branch density, nerve fiber length, everything, the story is the same everywhere. Dry eye. So obviously if you have a lower corneal nerve sensitivity, the dry eye is going to be worse. So if there's no sensation, there's no input or an afferent which says that the surface is dry, there is not going to be an efferent. So the watering is not going to be there. Reflex watering is going to be poor, right? So a surface approach also causes less tendency towards dry eye in patients with borderline tear film. So there are some cases in which there is already a borderline tear film deficiency, and some of them are computer vision syndromes. Sometimes they are not computer vision syndromes but also have a borderline tear film deficiency. Some of them are pre-rheumatoid, family history of rheumatoid arthritis. So these are borderline cases. So you look at the tear film makeup time in LASIK, the pre-operative, post-operative, and this thing, and you look at it after and look at the Shermer's test between LASIK and the PRK. Both of them are better. What about ectasia? We all know that because the corneas are surface ablated, the residual cornea is going to be thicker. So a thicker cornea is less likely to become ectatic. So there is a less risk of ectasia. This is the reference there's increased preference of surface ablation over laser in situ between 2008 to 11, and that is correlated to the risk of ectasia. So this has come out of Auckland. And you also look at the EFRSS score, the ectasia risk factor score system, and you'll realize that between surface ablation and LASIK, we are much better off with surface ablations. And obviously you don't have flaps. So with LASIK, there are flaps, and flaps have complications. And there are very dangerous complications. Some of the times the flap opens up, some of the times the flap is lost after some time. There is interface sands sometimes. Then there is an issue of glaucoma. So when you use the suction cup, and I'm not very sure whether this is true because there are very few reports in literature, but all the places where I have worked and I have a LASIK, I do a contact, non-contact with LASIK flaps. You have to be very careful when you do the gonioscopy. Many people don't do the gonioscopy. I do the gonioscopy without, I'll use an 8 mirror, I will not turn the gonioscope. And when I look at it pre-operatively, there are many of these patients where I have done the gonioscopy for a glaucoma evaluation pre-operatively, and the same patient has come to me post-operatively. I will see a angle recession in many of the cases in which a suction ring has been used. So there are very few case reports. Nobody has studied this so far. It has been my fault that I have not published these cases. But I have a series of patients in which you see an angle recession. And there is also a risk of retinal detachment because you're using a suction cup, and you may have an issue there. What in terms of corneal biomechanics? So when patients come to me for glaucoma evaluation post LASIK, or for that matter for glaucoma evaluation in any case, the most important thing is the corneal biomechanics. Is that how is the eyeball? Is it like a rubber ball? Is it like a tennis ball? Is it like a season ball? How much will it bend? How much is the expansibility? So there are variations in intraocular pressure, and if my balloon expands, the thin retinal nerve fiber layer inside is not pressed. So it's like me in a train, and if I am a fat man and somebody comes, my tummy can be pressed in, I won't die. Versus, and the walls are pliable. But if the walls are not pliable, and suddenly there's a rush inside, I will get pressed against the wall and I'll die. So corneal biomechanics is important in that sense. So I take a ball and I bounce it, and it bounces very high, which means it is very elastic. It can expand. So the death of an RNFL in terms of fluctuations of IOP is less likely. But if it's an unforgiving ball, it does not expand. A fluctuation of IOP will cause loss of RNFL. So what happens to the corneal biomechanics after you do a LASIK versus after you do a PRK? So when you're opening and cutting up a eyeball and raising a flap, obviously your corneal biomechanics are going to be disturbed. Versus when you're not raising a flap, the corneal biomechanics are not going to be disturbed. My evaluation of whether this patient is going to get a glaucoma or not have a glaucoma has a very important factor of corneal hysteresis, which we see with the corneal ocular response analyzer. This goes totally caput if a LASIK has been done. If a PRK has been done, the values are similar to pre-op corneal hysteresis, right? So PRK has the least impairment in biomechanical because there's only surface ablation. So that's comparing all of them. So the indications, the refraction corrections, globe contact, platform. Globe contact, I would like to say more because you're using something again and again. We have a propensity to reuse instruments, and post-COVID era, probably this is another thing that might be worth considering. The eye tracking systems and all of them are similar, but biostability is the strongest with trans PRK, whereas it's not so with. There are other advantages: thin corneas, epithelial membrane disease, and subtle corneal irregularities. Thank you. So I would ask you at the end of it, would you want to be Harshvardhan Ghorpade with a surface, or would you want to be Sunil Murikar with a LASIK? I think the answer is clear. Thank you.
Yeah, good morning again. My topic is transepithelial surface ablations, and is it old wine in a nicely packed new bottle, or is it something new? Is it slightly different from what we did in the past, like PRK? Is it the same or is it something different? I would like to thank my co-author, Dr. Siddharth Relan. No financial disclosures. So, transepithelial surface ablation basically speaks about procedures where we do not mechanically debride the epithelium. So, where do we mechanically debride? For example, in PRK, we do it manually. In LASIK, we use alcohol. In EpiLASIK, we use a PMMA separator, and there's some procedure called as EpiK promoted by the Israelis. So, we are not talking about those procedures. We are talking about a all laser procedure where we do not remove the epithelium manually. So, it could be a multi-step procedure like a PTK plus PRK as done on a Zeiss platform, or it could be a single step procedure as done on a Alcon, Schwind, or in a solid state laser platform that we have. So, these are the various platforms: Alcon, Streamlight, Schwind, TransPRK. Schwind has also come with a newer modification called a Smart Surface, and Zeiss allows you to do a single step procedure when you plan a topo guided transepithelial ablation. So, TransPRK is a term introduced by Schwind, but we all tend to use the same term for everything, just like we call Xerox for a photocopy. It's not like that. It's the original term is transepithelial surface ablation, where we do not separately debride the epithelium. So is it a some old wine in a new bottle, or is it something different? So does the way in which you remove the epithelium make a difference? Yes, it does, and I'll explain to you in the subsequent slides. So in PRK we use manual, as I said. LASIK we use alcohol. EpiLASIK we use a separator, which is quite expensive, and the all laser based procedures where we use PRK, LASIK, EpiLASIK, LASIK, or SMILE, even these are actually different from transepithelial ablation. In transepithelial ablation, it's a refractive procedure as well as a bit of a therapeutic procedure. While these procedures which I have mentioned here are all refractive procedures, which are all laser based, where we do not remove the epithelium, these are all laser based, but we do not have a therapeutic effect like transepithelial ablation. So, why does that happen? That happens because the excimer laser or the laser does not differentiate between the epithelium or stroma in TransPRK or transepithelial surface ablation. It does not differentiate. It removes layer by layer and does not specifically remove the epithelium separately. So, it removes a predefined tissue. So, we enter a predefined tissue. We know the epithelial depth, it's around, say for example, between 45 to 65. So, we enter that, say around 55 microns we enter it, but the laser does not know, and it just removes the it does not separate the epithelium, remove the epithelium separately, but it removes layer by layer, and we usually tend to take around 55 microns or 10% of the pachymetry, or if you have a slight variation in the epithelial map, then we take the average thickness. So, for example, this map is a 9 millimeter map, and as you can see, the epithelium is slightly different at various points. So, here we can take the maximum one is, that is 55, or sometimes we take an average, but here in such cases we take the maximum pachymetry, that is 55 as mentioned here. So, what happens in TransPRK? In transepithelial ablation leaves you with a smoother stromal bed, and that is why I say it's a therapeutic procedure along with the refractive procedure. Now, why does that happen? Because the epithelium acts like a masking agent. In this procedure, the epithelium acts like a masking agent, and therefore we have a therapeutic as well as a refractive effect, just like Contura. So, why does that? I'll show you in the next slide. For example, as you can see, when you lay a road, there are large stones or coarse gravel, then there is fine gravel, and then at the top there is sand. Now, what does the sand do? The sand fills up all the small defects of the gravel below it. So, for example, the Bowman's membrane is not as smooth as the epithelium. It will have some dents and some peaks, and these can be filled up by the epithelium. So wherever there is a slight wherever there is a slight peak, the epithelium is thinned out, and where there is a dent, the epithelium is slightly thicker, and it smoothens out. And this smoothness of the epithelium, is transferred onto the stroma in trans-PRK, and that is why it has a bit of a therapeutic effect. So and that is because it removes the tissue surface layer by layer, and the smoothness of the epithelium is transferred onto the stroma. Now this diagram shows it all. In the first picture on the left upper part, you can see the epithelium is smooth, the stroma is smooth, and after doing a trans-PRK you get a smooth surface. The next picture on the left, down left, you can see there is a slight peak, a small peak, like say for example early keratoconus, and here you can see when you do a trans-PRK, the peak is smoothened out, and you have the epithelium, the smoothness of the epithelium getting transferred onto the stroma. The upper right picture shows you that there is an epithelial defect, and if you have epithelial defect and you go ahead with a trans-PRK, you will see that the defect will be transferred onto the stroma. So it is always better to postpone the procedure, or at least be careful in such cases, especially while putting the speculum. If you have epithelial defect, I tend to push the procedure to a next date. And then this is the last part where you have a small old ulcer, for example, and if you take adequate epithelial depth, you can transfer the entire smoothness of the epithelium onto the stroma. So therefore the transepithelial surface ablations are not only refractive but to an extent therapeutic procedure. So that's the difference that we have in this specific procedure compared to other all laser procedures. Now there are some few cons, not exactly cons, but what happens if you get the epithelial depth wrong. So for you know the Munnerlin's formula. In Munnerlin's formula, the depth per diopter is equal to the diameter square divided by 3. So for example, if you take a 6 millimeter optical zone, you square it, it becomes 36, and you divide by 3. So 36 divided by 3 is 12. So the 12 for every diopter you end up eating up 12 microns of tissue. So for example, if you have a epithelium of 65 and you take enter as 55, so what will happen? You have a miscalculation of 10 microns, which approximates to a 0.75 diopter error. Do you end up with that error? No, that does not happen. Why does not happen? Because when you do, what exactly happens is that the only thing that happens is that the optical zone shrinks. So if you have planned for a 6.3, you might have a smaller optical zone. That's the only difference. However, the refractive error does not happen. So if targeted depth is more than actual depth, for example, if you have 55 and you have put 65, then there will be no change in the optical zone. Only one thing will happen is that you will eat up a little bit of stromal tissue. This can be explained by this diagram. You can see a plano-convex lens on the left. Now the power of this lens, for example, is 1 diopter. The entire lens is 1 diopter. However, if you take a plain cut and remove the upper part, even the residual lens will have a power of 1 diopter. And if you take a still deeper cut and you have a smaller lens over there, it will still be 1 diopter. So there will be no change in the power or refractive correction. However, the optical zone shrinks. As you can see, the upper part, the optical zone is largest, and the lowest lens, the smallest lens, will have the same dioptric power, but the optical zone will be smaller. This is further can be explained by this slide, these slides. So you can see when you take everything correctly, if the epithelium is 55, this is a Schwinn slide which actually does 55 in the center and 65 in the periphery. However, why they do that is that because the laser in Schwinn has a lesser fluence in the periphery, and to eat up more epithelium in the periphery beyond 8 mm, they use 65 as the offset. So therefore, in this, when you have everything correct, then everything is perfect. Your optical zone is 6.3 as expected. However, if the epithelium is thinner and you have taken slightly more epithelium in your offset and you have put it as, for example, if it is 55 and you have put 65, what will happen is that there will be no change in the optical zone, but the stroma that you eat up or take up is slightly more, so you waste a little bit of stroma in this situation. While if the optical if the epithelium is say slightly thicker and you take a slightly thinner value, then as I said in the previous slides, the optical zone will shrink. And this is the how it shrinks. For example, the original was 6.3 and then the newer one you got was slightly lesser. So that's the only disadvantage when you have a slightly wrong offset that you enter in the machine. And this is the overall table where it says that in the middle you can see at 6.3 you get everything perfect, but as you go slightly if the epithelium is say 65, 70 and you put 55, then you have a smaller optical zone right up to even you can go up to 4. If it's a small dioptric error, for example 1 diopter correction, then even you can have a 3 millimeter optical zone at the end. So Schwinn therefore does not advise you to do a lesser myopia, say lesser than 1.5. Dr. Chinmay will speak about it. So these are the various platforms we have. Streamlight from Alcon, TransPRK was the original from Schwinn, and now they have made Smart Surface. The Smart Surface is basically they use slightly lesser fluence towards the end of the treatment, so you get a smoother cornea at the end, and therefore what you end up with is slightly better quality of vision. What we have at our center is a solid state laser, which is has got a higher relay value. A relay value is what where we don't need to do extra correction in the periphery, and therefore we have a uniform epithelial offset all over the cornea, and also being a solid state, it creates less of regression because of the lesser heat generated at the surface. So the pros of in short are it's a therapeutic and a refractive procedure. It is good for irregular astigmatism. Post PKP it's really good. So what we are trying to do in these cases is transfer the smoothness of the epithelium onto the surface, and it gives a good better outcome in terms of the regularity in the stroma. If you have a topo guided treatment, the best option would be to use topo guided plus TransPRK, and that would give the best treatment in post PKP cases. Faster epithelial healing, because when you do a TransPRK you get an exact circle of epithelial debridement, while when you do alcohol you are going little extra. So obviously the time taken to heal will be faster in TransPRK or transepithelial surface ablation, and obviously there will be slightly faster visual recovery that we have seen. Lesser haze because of I would say in flying spot lasers we have lesser haze. In the original broad beam lasers we used to have more haze, therefore we used to go only up to 6 diopters. But with the new flying spot lasers, and the most important is using of MMC. I would advise you to use MMC in every case, whatever it is. Some people tend to have 10 seconds per diopter, but nowadays we just use it for 1 minute for all cases, and we end up with very good results. And we have even done higher myopias up to -12 in adequate corneal tissue availability. And therefore it's a true non-touch procedure where we don't touch, we don't cut, we don't have flaps. You can call it like a blade free, touch free, flap free procedure. It can be, you can sell it as a premium procedure like Alcon does it, and it is novice proof because anybody can do it. Even a novice, a resident can give a similar result like a consultant, because there is not much learning curve in this touch free and blade free procedure. And cons, as we discussed, we can have a smaller optical zone. In hyperopic cases it can be slightly difficult. If you get the epithelial depth wrong, you can have a smaller optical zone, and in turn, because the optical zone and the transition zone are not continuous in hyperopia, you can have regression. So you have to be very careful in to not to get the epithelial depth wrong, especially in hyperopic cases. That's one important point. And retreatments also can be difficult sometimes, because you have epithelial hyperplasia in cases of retreatment in regression, and there we end up with a slightly smaller optical zone. And TransPRK has, because the always has 4 times more pulses that are given on the surface as compared to usual LASIK, and that can end up with haze, especially with the broad beam lasers. As I said, MMC has to be used in every case, and it is best avoided in epithelial abrasions because you will end up pushing the epithelial abrasion onto the stromal surface. And difficult cases are low myopia. So if you have a low myopia, you will end up with a very small optical zone if you get the epithelial depth wrong, as we discussed as per Munar-Lins formula. So therefore, always take slightly extra epithelium, because anyways in low myopia you don't end up wasting lot of stromal tissue after the laser. And you can also take a slightly higher optical zone. I tend to go up to 7.5 in such cases, and you can really get good results with low myopia. In hyperopia, if you are not sure of the epithelial depth, it's better to avoid, because you can end up with a lot of regression, because in hyperopia, as I said, the transition epithelial and optical zones are not continuous, and you get a sudden increase in the sudden increase in the steepness of the cornea, which can, when does regression occur? When you have a sudden change in the steepness, and regression progresses from the periphery to the center. In myopia you have a central ablation, so it's a natural smoothness that you have, but in hyperopia you have a dent and then a sudden increase in the steepness, and that can cause regression. And to get smoothness, you have to smoothen the peripheral transition zone, and for that you need to get the depth right. And in enhancements, as we said, if there is epithelial hyperplasia, you put extra epithelium in your offset. This is the solid state laser we have, where custom is which we use, and I'll just use another 30 seconds to show you how easy the procedure is. This is a real time video, but I'll still fast forward it a little bit because of time constraints. So you just put the drape and the speculum, and this is just drying the surface. In solid state laser, you don't even need to dry the surface because it is humidity proof, and that's it. You start the laser, it just does the surface treatment, and after that you can just see the ablation done. You put little bit of MMC, and you give wash with saline, and that's it. So no touch, no plate, no cut. That's the advantage with smoothness transferred onto the corneal surface, and you have to take care of the epithelial offset. That's all. Thank you so much for patient listening. Our next speaker is Dr. Chinmay Sahu. He's from Sahu Eye Hospital, Malad, senior fellow from Shankar Nethralaya, and also faculty in LVP, and he's going to speak on smart surface.
We've seen that in some irregular astigmatism, you said that it is a good procedure of choice for irregular corneas, or probably even in PKP, post-PKP cases. But we know that the epithelium does hypertrophy in certain areas where there is irregularity.
Yes.
Then won't that, falsely, because if you're comparing it, or rather supplementing it with the topo guided, it may help.
Yes.
But how else? How will it help in?
So as I said, in such cases where there is epithelial hyperplasia, it's better to have the pachymetry maps. The epithelial maps, and definitely you should put a slightly higher value and try to maintain the optical zone in such cases to get the better smoothing. Because if you have,
when you are tweaking the optical size, is it a machine specific tweaking? Because I believe
it is machine specific.
Yeah, because the EX500 that has a specific optical zone.
No, we can change the optical zone.
In which machine, sir?
In our machine we do it regularly.
Okay. So that is machine specific. It's not for every trans PRK.
With the newer platforms for trans PRK, they have introduced this feature in all the newer machines. So
you would still prefer in an irregular cornea to do a trans PRK?
Yes, definitely. You get the smoothness of the epithelium transferred very nicely onto the stromal bed, that you can't get with any other all laser based procedure. That's what we.
Okay. Thank you.
Am I audible? Yeah. Good morning, everyone. I would like to thank AIOC for giving me this opportunity, and Harshvardhan for inviting me for this instruction course. Now, the previous speakers have clearly explained that the difference between PRK, where is mechanical removal in PRK, whereas the laser removes the epithelium in trans PRK. Now, my experience is limited to using the Schwind Amaris, which we have at our center. And I can say that the advent of this machine has revolutionized the surface ablation procedure. Now, what are some of these features? It's got an extremely fast pulse rate. In fact, here I've mentioned 500 Hertz, but the newer machines have 750 and 1050. So it takes hardly 2 seconds per diopter in myopia. Then it has got an amazing 5D tracking system which prevents decentered ablations and accounts for cyclotorsion. It has an asymmetric offset. What I mean by this is when the laser fires, it takes the corneal vertex as the optical axis of the ablation, and the higher order aberrations are treated to the pupil center. So this prevents certain kind of higher order aberrations like an coma aberration from defocus correction or a trefoil aberration from astigmatism correction. Other salient features are like intelligent thermal effect control and automatic fluence level adjustment. Now, this is a small video which just shows almost what is happening. So, that in the Schwind Amaris, it's an extremely versatile machine where they say that the epithelium removal is actually refractive neutral, and they have different ablation rates for removing the epithelium and the stroma. And one of the reasons why it works well is that it leaves the surface very smooth and is an excellent tool in doing a lot of things on the surface, like, you know, when you're dealing with irregular corneas, as the previous question was directed to, or when you're dealing with borderline thickness cases. So, as I said, the ablation profile consideration, it is a refractive neutral for the epithelium removal and has different ablation rates for the epithelium and the stroma. It makes an assumption that the epithelial thickness is 55 micron in the center and 65 in the periphery. But with the upgrades which have come, you can actually, you know, enter the epithelial thickness, though the company says that you did not change it. So you can actually do an epithelium map on the spectral domain OCT and try and titrate it. But because they claim it to be a refractive neutral procedure, they really don't advocate it. Now, what are the advantages? It's obvious that it becomes simpler, quicker, lesser pain, lower grade of haze, and a faster reepithelialization. Now, with the advent of the smart, surface treatment, basically in smart surface, it makes an assumption that the cornea is not a flat surface, but it akins it to a Fullerene structure. Now, what it does is it leaves the cornea smoother post the procedure. So here you have two images, which are, one is post a without the smart pulse, and the other is with the smart pulse, and you can see that in this electron microscopy picture that the surface appears smoother. It also reduces the roughness by around 60%. Now, what does this mean? In one of the studies where they looked at around 50 patients and divided them in two groups, where you had the classical trans PRK and then the smart surface group, they looked at the day of epithelialization, the uncorrected distant visual acuity on the day of epithelialization, and the pain score. Now, whenever we talk about surface ablation, one of the biggest hindrances to, is the people say that there's no wow factor, the amount of pain that the patient experiences, the uncorrected distant visual acuity takes time to settle in. Now, with the next few slides, I'll try to debunk some of these myths. Now, here you can see that almost like the day of reepithelialization is the second or third day in most of the cases, though it actually depends on the amount of diopter that you're treating, and the uncorrected distant visual acuity actually is much better. In this multicentric study, which covered around 1,000 eye across 8 centers, they have shown that up to 30 minutes after ablation, if you take the patient and make him sit and see the Snellens, almost 65% of the patients have an undistant visual acuity of 20/40 or better. And this is not bluffing. I mean, this is something which I regularly do in my practice. We make it a point to show to the patient that you've already improved. And this takes away some of the inhibition when we talk about surface ablation, that, there is no wow factor to it. 90% of these eyes achieve 20/50 or better at day 1. So my first point is, please take away this, that the uncorrected distal visual acuity is not good at the first day. The second is the efficacy. Even at 1 month post-operatively, the efficacy is excellent. 84% of the eyes had less than 0.5 diopter of astigmatism in this particular study. So now let's look at some of the concerns. corneal haze is something which everyone talks about. Wherever I speak, and people always say, "Nahi yaar, corneal haze hai," and when you're dealing with high diopters, it's a big issue. Now, if you look at corneal haze, you have early corneal haze and late. I won't go into the details of this, but there was a beautiful paper from the Narayana group which got published in IJO, and where they did a retrospective study and tried to kind of come up with a risk score for trying to see whether, looking at a patient preoperatively, can you actually look out for which are the patients who are likely to develop corneal haze and kind of segregate them. Now, this is what they did. They looked at contact lens intolerance, TBUT, gland dropout, OSDI scoring, vitamin D levels, and the working environment. And they gave some scores to this, and they divided these patients into 3 groups: low risk, moderate risk, and high risk. Now, please look at the next slide. Only 1 out of 235 eyes in the low risk group developed any kind of haze, which is 0.4%. So if you are very good with your pre-op screening, this concern about haze is actually not there. Even in the high risk group in their particular study, 4 out of 88 eyes developed a bit of corneal haze. Now, what about us? We have, till my last data was collated, it was around 491 patients, both eyes were 514 patients with 982 eyes, or 1005 eyes treated. And we have treated around 20 patients in the -8 or plus group. Only 1 patient developed some kind of haze which was persisting at around 3 months, but again with treatment with loteprednol, cyclosporin, this reduced over a period of time, and the patient was never symptomatic, mind you. This haze was just something that I was noticing when I was seeing the patient. So corneal haze is an overhyped thing post-surface ablation. Some of the other data, this particular paper from Abid Mogaddam et al., which looked at high myopia. This thing comes across above 5, it is no longer a safe procedure. So they looked at -6 to 8.75. And in this particular also, they had just 1 patient with trace and another eye with grade 1 haze. So there is enough data to say that corneal haze, especially with a platform like the Schwinn Amaris, is hardly an issue. It's not an issue. And if you look at plan your pre-op screening, which carefully, you're not going to face this. Now, what do? We look out for a history of chronic allergic eye disease and keloid formation. These patients, you got to be a little careful. Please do your OSDI scoring. Look for mebomitis. If you have any underlying chronic allergic disease, treat it with an antihistaminic. Start the patients with calcirol if the vitamin D3 levels are low. Look at the OSDI scores. If you find that the lid margins are inflamed, start a patient on doxycycline along with azithral. So if you are a little patient, and if you're not just concerned about losing the patient because you're going to set up some time before you take the patient for the procedure, I can assure you that you're not going to see any post-op corneal haze if you've been careful with these things. Intraoperatively, smart surface treatment, I think, is revolutionary, and that's the greatest, I think, technology advancement that has occurred. Using mitomycin C with a 0.02% concentration, and I do it for every diopter, we do it for 10 seconds up to 60 seconds. Post-surgery, topical steroid, whether you start on day 1 or you start later, has been a little controversial, and I have veered between 2. Concerns about infection initially made me look at it, but right now we start with the loteprednol right from day 1. We keep the patient on vitamin C for a month. Calciol, 1 sachet with milk once a week for 4 weeks. And again, if the patient had any pre-existing issues, like an poor OSDI score, we look into that. Another thing that we are very particular is talking to the patient about their lifestyle. Mind you, UV light exposure, especially when the patient goes out in the open. Let's say the patient has an active outdoor life and he's going out for walks or runs in the morning, then you're going to get a little bit of haze. So we are particular to look at this and instruct the patient accordingly. Now, we've talked about the safety, the haze part. Now, what about efficacy? This is another thing that comes in. LASIK is much more efficient. Femto-LASIK is wow. SMILE is the best procedure that could have been there. But let's look at data. This meta-analysis, which looked at 1924 eyes, actually showed the efficacy was around 94%. And if you compare results, if you look at this particular study, which looked at 85 eyes and in almost roughly 80 in each group between femto and the trans-PRK, the uncorrected distant visual acuity was almost equal in both the groups. And in fact, at 1 year, the refractive predictability was found to be higher in trans PRK compared to the femtolasic group. So, there are papers which would say something otherwise also. Now, here we are not out to compare two procedures. What we are here to say is that trans PRK has excellent efficacy and gives excellent visual outcomes. Even when you compare it with SMILE, you will find that the data suggests that refractive power is similar post trans PRK and SMILE, and that the uncorrected visual acuity, there's no significant difference between the two procedures. Now, astigmatism. Now, again, my initial concerns when I migrated from lamellar procedures to surface ablation was, would I get accurate corrections for astigmatism? Now, look at the data out here. In one of the studies by Z et al., which used vectorial analysis to look at the SIAs, they found that 100% had an uncorrected distant visual acuity of 20 or 20 better, and residual cylinder was less than 0.5 diopter in more than 93.6% of the cases. So it goes on to show that even in astigmatism, it is an excellent tool. When you compare it with SMILE, in fact, I would say trans PRK stands better, because here you have an option of looking at cyclotorsion because of the amazing 5D tracker on the Schwind Amaris. Whereas when you're doing SMILE, because there's a docking system and you have to do a mechanical marking of the axis, the amount of astigmatism correction, if at all, is slightly better with trans PRK. What do? I actually go onto the Alpine's calculator online and I look out for what I call the they have a nice nomogram for the ocular residual astigmatism, and I feed the data into this calculator online. And at times, if I feel like on the trans PR on our machine, you have an aberration free mode and a corneal wavefront guided mode. Normally 95% of the time you need an aberration free, but if I'm dealing with astigmatism, I would go on to this particular calculator and then use this to decide my final treatment. So like if you see out here, you will see that the corneal power out here was 42.5 and 45.5. The refraction was -3 with -2.5. So they have an option where you can treat 60% refractive and 40% corneal. So the intended treatment changes. Now I have found this to become a very useful tool when I'm dealing with astigmatism, and I tend to get much better corrections after I've adopted this in my practice. So whenever the ocular residual astigmatism is more than 1, I use a ORA calculator. You have to go to assort.com. It's freely available. And then I use the 60-40, whereas 60% is refractive, 40% is corneal, and I do accordingly. Now, what are my applications? Whenever I'm dealing with a thin cornea, which seems to be very common in our patient population, you quite often have situations where a patient has a 470, 480 corneal thickness, where you aren't quite sure that you cannot do a lamellar procedure. In these kind of patients, then this becomes a great tool. Now, sometimes, you have patients coming to you with a Corvisca reading, which shows that the biomechanical stability post, is not, the biomechanical strength of the cornea is not that great. But data from Narayan Netralaya, where they have done polarized anterior segment OCT studies, and they've compared the corneas post trans PRK, post lamellar procedures, collagen cross-linking, and they've found that the cornea seems to be, in fact, a little bit, it's quite stiff and strong after a trans PRK procedures. And that has enabled me to do a lot of trans PRKs in a borderline situation. So when we have the ectasia risk score and where you are in the moderate risk zone, I land up doing a surface ablation. So these are like those examples where you have a thinner cornea. When you're dealing with corneal opacifications, it's an amazing tool, very versatile. PRK extra, so sometimes when you're dealing with keratoconus patients and you have a good corneal thickness and you want to kind of give the patient a better refractive outcome, you can actually first ablate the cornea and then land up doing the collagen cross-linking. When you have flap complications post-lamellar procedures, again, it helps you, and it's a very versatile machine. Now, I just wanted to close by saying that not all is rosy. We went back to do a little bit of an analysis of our patient satisfaction, because one of the concerns in private practice is, am I overdoing a procedure and am I missing something out there? Am I not smelling the coffee proper? So what we found that the pain factor was around, it wasn't as great as the studies were saying. There were patients complaining of pain, and commonest were in the, they graded pain on the scale of 5 to 10. However, when, they are explained that when you're doing a lamellar procedure, there are certain flap complications that can happen versus a slower recovery. Almost, they said that 87% said that they would recommend this procedure to their friends, given the fact that it is safe. And generally, what we are doing now is trying to do an analysis at 1 week and later at 1 month. So what we find that what a person feels at the end of 1 week versus what he feels at the end of 1 month changes. And once they start seeing the difference in vision, they are more happy. So I would like to conclude saying that it's an extremely safe and effective procedure. I do it where LASIK is clearly contraindicated. Steep corneas, flat corneas, when you see hot spots on topo where you're scared that, if the keratome goes through, you might have flap complications. Thank you for your patient hearing. Thank you.
Thank you, Chinmay, for a very nice talk. Our next speaker is the last speaker, Dr. Praveen Krishna Vadavali, who needs no introduction. He is a cornea and refractive head at LV Prasad Eye Institute, a innovative surgeon and a innovative speaker with amazing presentations. Over to you, Dr. Praveen.
Thanks a lot, Harsh, and also thank you, Chinmay, for speaking. Can you hear me all right? Yep. Okay, thank you for speaking about PRK. The reason why I say that is because typically in most meetings, even at AIOS, PRK is one talk in a session about refractive surgery, and usually is not given a lot of precedence or importance, but it's very rare to have an instruction course on surface ablation by itself. So actually, good job, and thank you for bringing this up. I'd like to speak to you about PRK, or what is also called advanced surface ablation. And typically, you've heard in the earlier talks how PRK or surface ablation is supposed to be limited only to a small group of patients who are not suitable for other forms of refractive surgery. But what I want to share with you is to tell you why we've actually transitioned from PRK as a secondary procedure to PRK as the procedure of choice for the majority of our patients over the last several years. Again, going back in time, this is the patient that actually I always share, and this is a patient that I still see to this day. This was a patient seen in 2002, if you look at the screen on top, and she was a young doctor who came in for LASIK at that point of time. Then I think we were operating on the Zeoptics system along with the Zeoptics XP microkeratome. So she underwent a microkeratome LASIK about 20 years ago, uncomplicated, flaps were thicker in those days. She had a very good residual stomal bed, normal topography, maybe slightly on the thinner side. But then I saw her when she came back about 5 years later, and she started to develop some astigmatism and some inferior ectasia. And before cross-linking became more available, 8 years after surgery, she developed full-blown ectasia. And again, this is just one patient of several that you tend to go back and look at and wonder, what did you do wrong? Because if you probably did this surgery again, you probably would do a LASIK, maybe with a different microkeratome, but still you would expose yourself to the risk of ectasia. And like Chinmay spoke to you about, post-LASIK ectasia is a real issue, especially because of the fact that when he mentioned the Randleman risk scoring system, one point that is very interesting is the fact that being young is an automatic increase in the risk score, and most of our patients are actually quite young. And the average age at which we do LASIK in India is about 23 years. The average age at which LASIK is done in Caucasian population is 36 years. And being 23 already gives you 2 points in the risk category. Lesser than 1 is category 3 risk. And from that perspective, automatically surface ablation is a better procedure than LASIK. And there are several case reports, at least 3 that I found, where patients who had normal topographies underwent LASIK in one eye and PRK in the other eye. They developed ectasia in the LASIK eye, did not do so in the eye that actually had PRK. And if you look at literature of ectasia and associations with procedures, obviously the most common correlation is with LASIK, where you have the highest reported incidence or number of cases after surgery. SMILE is starting to be reported more recently, which is again unfortunate. There are very, very few case reports scattered in the literature about PRK and ectasia, and if you look at them, most of them are actually in patients of keratoconus where there was pre-existing ectasia before. So again, what causes ectasia? And we really do not know what causes ectasia truly, but then again, it seems as if LASIK and SMILE do increase the risk of having ectasia, whereas PRK doesn't do that. So this is a very interesting slide because it actually shows you the journey at LVP, and from 2010, where 70% of our laser procedures were all LASIK surgery, about 27% was PRK, 5% was phakic IOLs. We've transitioned in 10 years to about 70% of PRK, 25% of LASIK, and a small percentage of SMILE and phakic IOLs. And this is a journey that probably is also because of the previous slides that I showed you, but also because of the fact that the outcomes that we've had with PRK have been fantastic. So this is about 10,000 eyes data, 5,000 patients who underwent PRK, much larger than most other published series, with at least a 1-year follow-up. Majority of our patients were in the error range of 3 to 6 diopters. There were a significant number, 5%, who had more than 9 diopters of refractive error. Average age of all these patients was about 25 years, and the mean spherical equivalent in each of these 4 groups, we divided them into 0 to 3, 3 to 6, 6 to 9, and above 9, was 2 diopters, 4.5 diopters, 7.5, and about 10.3 diopters as well. And when we looked at the outcomes of PRK in these patients, the outcomes actually were quite comparable between these 3 groups in the relatively lower myopes. And you'll see that the accuracy of correction or the uncorrected visual acuity, 20, 25 or better, 99% of patients actually had that visual acuity up to 6 diopters, and between 6 and 9 diopters, 97% were better than 20/40, and this is also because some of these patients did not correct to 20/20 before surgery as well. When we looked at the accuracy of correction within plus minus 0.5, 98%, 98%, and 95% up to 9 diopters, which is actually better than most other refractive procedures, including LASIK or phakic IOLs as well. Stability too in the 3 groups we found was equally good. Up to 12 months, there was really no change in the refractive error once they reached their final refractive error or final vision at the end of 1 month after surgery. So what about really high myopia as well? So we've had experience in operating PRK in very high myopes. An example is here. This is a minus 11.5, minus 2 refractive error. Patient was corrected to 20/40 before surgery, and she had a shallow anterior chamber, so we can do a phakic IOL. We did PRK for her. This is her about 6 months post-op, and she was plano 20/20, and she continues to be this even several years after surgery as well. So PRK seems the fact that we can expand the correction range of PRK beyond what we typically would do or what is advisable of up to 6 diopters. And we found that when we looked at our patients who had myopia of greater than 9 diopters, we found that the accuracy of them being within plus minus 0.5 was close to 80%, which still is exceptionally good compared to any refractive procedure in this quantum of myopia. And within plus minus 1 diopter, there were 93% of patients. The mean sphere in this group was minus 9.5. Mean spherical equivalent was about 10 diopters, so very high myopia, who underwent PRK with at least 1 year follow-up. So when we compared this with patients who had myopia of 1 to 3 diopters, the correction accuracy was as expected, slightly lower, but the stability was equally good in both these groups, which again negates the worry that high myopes tend to regress more after PRK compared to lower myopes. When we looked at haze again, haze certainly is something that you will see. And you look at these bars, only the red actually is severe haze, which is impacting vision. Several patients did have haze in the early post-op period, but then towards 12 months, most of these patients did not have any haze. And the only ones who had severe haze, who actually required intervention, were mainly in the group between 3 and 6 diopters, probably because this is the largest number of patients in this group as well. So what about how many patients we needed to reoperate for haze? So when we looked at our data of about close to 14,000 PRKs, that were part of our electronic medical records, only 21 patients required repeat PRKs out of these patients. That's a reoperation rate of 0.15%, which is actually significantly low. And when we started to look at what was the cause of reoperations, we found that about a quarter were undercorrection, quarter was overcorrection, a quarter was residual power. So 75% because of refractive errors and only 28% because of haze. So only 6 eyes out of 14,000 actually required repeat PTK or repeat surgery for post-PRK haze. That's 0.04%, better than endophthalmitis as well. So the only interesting point is the fact that when you see patients who have higher myopia, they also tend to take slightly longer for them to come back to their preoperative best corrected acuity. Those who have higher astigmatism and high myopes, it can take up to 3 months for them to actually recover their vision to their preoperative level. So again, to get back to why surface ablation, again, like I showed you in the earlier slides, ectasia is something that all of us are going to face. We do not really know when it's going to happen or why it's going to happen. It's something like end-off, and I believe that all of us do whatever we need to do to prevent end-off, but we're not going to be 100% sure it's not going to happen to us. With PRK, you also negate several of the complications that happen with LASIK as well, and also because of the fact that it seems to be very predictable from the data that we have right now. And interestingly, most of our patients who come in for surgery right now, because they are word of mouth and they're referred by other patients, a lot of them actually ask for PRK by choice. And it seems to be a practice change that has happened, especially in Hyderabad, and that actually is something that is very heartwarming to see. And it is something that is more comfortable for the doctor as well as the patient. And I sincerely believe that when you do refractive surgery or any surgery, safety probably is the most important perspective that you have to talk to the patient about. And when you speak to them about this, almost everybody is willing to undergo PRK. And I'll end with a photograph of my cornea. That is my cornea actually. So I had PRK myself about 5 years ago, and you can see that there is no haze. And that is my cornea. If you want, you can have a look at it in the trade. So I was a -9 and a -1.5, and I would not have had PRK if I did not believe in it. And I am 20/20. These are my reading glasses that I wear all the time. They're +1s. So this is something that I'm really happy about. And I also believe that I took this call after seeing several patients doing really well. And I think no regrets for PRK. Thank you very much. Yes, of course.
Do you have any cutoffs that you follow for every PRK patient? Like, for example, in LASIK, we keep a minimum RSB, or the maximum ablation that you would do is such. Are there any such cutoffs that you follow, or it's customized depending on every patient?
Because RSB values are the same for PRK and LASIK, we tend to use the same correction. So absolute minimum RSB is 300 microns.
Okay.
I tend to stay above 325 if I can. Okay. Maximum ablation in PRK is 140 microns. I don't go beyond 140 microns. That's quite a lot already.
Yes.
Yeah.
Okay, and then when you said that over time the longer, or rather the higher myops take a little longer to settle, why do you think that is so? Is it the epithelium that is settling in, or as in why do we need to give them that much time for their preoperative BCVA to come back? I
think it's the epithelium. Really nothing much happens in the stroma. So the epithelium relayering and smoothing actually takes more time in high myops, and especially those who have high astigmatism as well. So
Okay.
it doesn't seem to be something to do with stromal healing, but it's the epithelium that actually remodels over time.
Okay, and I think as Dr. Sahu has mentioned that preoperatively, I mean, we don't really test for vitamin D in every patient, but what are the things that you can see before, so the perfect score that they say, you should know what are the patients that may be exposed to haze. The numbers say that there are very few, but what can we do in a practical, scenario where we can say that, okay, a 9 diopter myopia, which is going to be treated, will not go into haze. So do we do anything beforehand, or just start a empirical vitamin D therapy or vitamin C, any trips with that regard?
No, I don't think so. I think all you have to do is to be open to it. I don't think vitamin D and a lot of other factors really, just like COVID, all of us thought vitamin C is preventive, so we started popping pills. This is something like this. This is like a shot in the dark. And I don't think there's any proof to actually say that vitamin C or D actually have a bearing on haze. We don't do anything specific for our patients, but I think there are 3 factors that are important. Number 1 is mitomycin C during surgery, like what Dr. Chinmay showed you. Number 2 is to ensure that you use low-dose steroids for an extended duration of time. And number 3 is UV protection. So these are the, I'm sorry? Steroids for powers that are above 6, we use for up to 6 months. Loteprednol once a day or twice a day if required, and for powers that are less than 6, we tend to use it for 3 months.
So have you seen any cases done PRK and surface ablation, and after a few years, like the patient was all right, he went to some, say, snow area or wherever, lot of UV, and he developed haze or something?
I think it's good to have UV protection even long term as well. We don't insist on it after the first 6 months when we follow them, because I don't think it's really possible to make a change in lifestyle to that extent. But I think it is useful to know about the risks of UV. I don't think we've seen patients who've had very late haze who've come back to us recently, at least.
Like for us, patients, people who want to join army or police,
Yeah,
they come and they ask for PRK and we do it.
true.
And so yesterday there was a course, and one lady, I think ex-army officer, she almost made all PRK, people doing PRK look like criminals.
Hmm.
The soldiers, they come
Yeah.
back with UV haze and you guys are not looking into it and all that. So don't do PRK. So okay.
Like I said, I mean, I put my money where my mouth is. So if I did not believe in it, I wouldn't have it. As simple as that. And I think it has to do with the steroid regime as well. For those who develop late haze, if you stop steroids early, I think the risk of developing haze late is actually quite high.
I mean, if you see the haze, do you put any other medications on? Like, is there a role of cyclosporin, or you just observe it?
No.
Observe.
Haze generally is better prevented than treated.
Treated.
Once you have haze, you can't really do much about it. So do everything that you can to prevent it rather than treat it later.
Commercial question: where do you get those circular merocils that you can put on the cornea for the MMC?
I don't use them anymore
No?
because they're
How-
difficult to source. So all I do is put a drop of mitomycin C on the cornea, spread it evenly. Because the simple problem is you will not find a sponge that conforms to the shape of the cornea
Correct.
anywhere. It's only going to touch in one area.
Correct.
So put a drop of mitomycin C and spread it over.
It
So
doesn't
that way,
matter if it goes everywhere. It just
no, once
cold
you have your
wash.
cornea dry and you put a drop and spread it in the optical zone area, it's not going to flow away. It'll just stay there and then wipe it off after you finish.
Thank you so much.
You can again, but contact is a problem because it might not touch all the areas that you've ablated, but a drop ensures that you have contact in all areas, so it's simple.
So do we put cyclosporin routine for all PRK?
No, we never use cyclosporin. We don't use it. Yeah.
Can I
Any
button
difference
in just take
Sorry.
a couple of points out
Yeah.
there? For the point that you made, see, quite often what you do in practice is not because it's needed, but because it might help you in a medical legal situation. Now, when you look at LASIK, All India, the AIOS comes up with a recommendation of 480 microns. Now you have people doing Corvus studies and showing that the biomechanical strength. So the question out here is, if tomorrow one of your patient lands up getting it, and if at all he goes to a tertiary center. Now in India, Narayan Netralaya probably is now, sir out here obviously is there, but on the Shwin Amarish, Narayan Netralaya has maximum, and you saw the perfect study which they came up with. So quite often I do it not because I think it's needed, but I just do it because in case I land up in the soup, it might help me. Number one. Number two, like there is no harm. Sometimes you just do it. It allays some kind of fears that you might be carrying. But I can tell you that with the smart surface ablation, I think haze is just out of the picture. We are regularly treating higher and higher myopes now. The second point which Praveen was trying to make was he's mentioned that up to 3 months is what they have seen, the corrected visual acuity to come by. Actually, yes, it takes the epithelialization takes a bit of time compared to the lower myopes, but the UDVAs, if you call them at 2 weeks, and if you call them and I think it's mainly to do with the dry eye part of it. More than anything, it's just that the tear film is stabilizing in these patients. At 1 month, I think bang on, most of these patients are 6-9 or if not better. I wouldn't say that 3 months is the period that you're looking at. Third part was, ma'am, in terms of what sir does is he applies a drop of mitomycin. I've tried with the Veckels, the Merocil sponge that you talk about. But what we do is we take a bit of cotton. The sister just kind of, it's a circular manner cuts it. We dip in mitomycin, squeeze it out completely, and we then place it on the cornea. This, to my mind, is helped me a lot. Earlier when I was using the sponge, one part you've applied, the other part is dried up. You don't know whether you're evenly applying it to the surface. And the other worry of the mitomycin going into the conjunctival surface and causing a lot of inflammation or irritation. So when you do it with a cotton, squeeze it out and apply it on the surface, it takes care of any kind of irritation or those concerns that you could have. And we don't use any cyclosporin routinely. It's only, yes, if you see a little bit of haze happening, now no one knows. Once you start seeing, as Sir said, that haze is better prevented rather than managed. But once you start seeing it right from oral steroids to Talimas to using cyclosporin, it's anyone's guess, whatever. But telling patients, one thing we noticed was this outdoor UV light exposure, which you say, the UV light. At least for the first 3 months, we are very strict with our patients. We recommend them not to go out when, and do outdoor activities when the sun is out, or to use UV protective glasses if they're doing it, though we strongly, discourage that.
Which of the platforms, like Schwind versus Streamlight, which one are you using, and any obvious pros and cons?
But before I actually say something about that, I think, Chinmay, the question about patients getting better, I think to be realistic, this, I can't see my slide, but it's not about what I think or what you think, but this is data from several thousand patients. So what you say is true.
The papers which I had shown were actually studies on the Schwind Amaris.
Correct.
The multicentric study, the meta-analysis of 1924 eyes.
Yeah.
Actually, at 1 month, the uncorrected visual activity was close to 94%. That means your best corrected upon your uncorrected, the pre or post-op, it was 94%. So that was a 1 month figure which they mentioned. So I think the jury is out there. Frankly, data is out there and data is equivocal. You could skin it both ways.
Yeah.
But on practically what I've noticed in my patients is what I mentioned actually.
That's true, and I tend to agree with you. So what I said was recovery of vision for high myopes is what takes time, and not the low myopes. Up to 6 diopters, I think in a month, the majority of them are at 20 by 20. Right. But for those who are higher myopes, because of the fact that, like you said correctly, I think it's a dryness as well that has a
role to play out there.
Yes, but then the simple question is, when you ask them to put a drop like Optiv on the eyes and then see if the vision improves or not, that usually is an interplay between the smoothness, adequacy of the tear film and the epithelial thickness as well. But going back to your question, ma'am, about the platform, I think everybody is going to be speaking about the platform they use because that's the one that they know the best. I really do not think one platform is better than the other. And I think as a group, I think it's the PRK that we are all voting for right now, to say that this is a procedure that can be as good as any other refractive surgery and is safer than what we are currently doing in LASIK. We use the wave light.
That's the point that I would like to make. When I started with refractive, I'm a trained retinal surgeon. In fact, was a consultant in retina at LVP Hyderabad for a while. So when I started, I had no background in refractive, and I was doing 70-75% lamellar procedures. So when the microkeratome is new, you never see flap-related complications. It's as when you keep using it over a period of time, you start noticing. 3rd, 4th year of my practice, I had my first few flap complications. And believe me, my heart sank. When you deal with your flap complications, a flap wrinkle, a flap, when you develop any kind of buttonholing and then you have to manage epithelial ingrowths, that's when I actually started migrating to it. So I would start by saying that do no harm should be the first motto of any doctor or any procedure that you do. You're doing a procedure and a person who has a BCVA prime almost of 6.6. So if you meet a problem after that, it becomes difficult to handle that. So, and surface ablation is, people want the wow factor, and doctors keep coming to my center and there is no wow factor in PRK. What I want to do is debunk these myths, come out with data which shows that it's equally safe, predictable, and if you counsel the patient adequately preoperatively, all my patients today go for PRK. And the one big thing that happened when I interacted with Rohit was that I started charging almost 25% more for my surface ablations. So it takes away from the patient's mind that you're doing something inferior. It's actually something that the machine allows you to do because of its superior technology and should be charged adequately.
Yeah.
My laser platform is EX500, and like I said, I don't think the platform makes a huge difference. I think they're all the same.
Yeah.
So could you please elaborate on post-op treatment, when to start steroids, when to remove the BCL, and
also
are there chances of infection in trans-PRK?
Yeah, I think again, practically steroids, what we start the first drop of steroids on table. So the patient gets a drop of steroid as soon as the surgery is done. Steroids started on day 1. We start with loteprednol 4 times a day. and then taper weekly and keep them on twice a day for about a month. After that, if the power is high, I'll keep them on twice a day for up to 3 months and then cut down to once a day for 3 months after that, so 6 months. If the refractive error is less than 6, then they stay on 1 time a day for 3 months. And if required, then I continue them slightly longer. If they have allergies or if it is summer, then I tend to use it 1 time a day for a longer duration. Antibiotics till the epithelial defect heals. BCL typically at 1 week. Earlier, we used to be very worried about infections and we used to see patients very frequently. Now we don't see them till the first week post-op. We do a teleconsult online, so we actually save a visit for the patient. 1 week later, they come in, we remove the BCL. Also, we don't give them the opportunity to complain about the pain if we don't see them early. And after that, the artificial tears for 6 months or so.
So,
no, in fact, one of the faculty members at our center uses prednisolone 2 hourly. All that does is cause more glaucoma, but it doesn't seem to increase or reduce the incidence of haze because we looked at numbers and we found that the haze was just the same if you use lodiprednol or predform.
At our center, we are using, we don't use steroids for the first 1 week, especially for myopia up to 6, because we don't want to take the risk of infections. Everybody has the stress of BCL there. So we start the steroids only after 7 days after removal of the BCL, and we have not found anything different in terms of the final outcome. Also, because of MMC, it has made a huge difference. The third thing I would wanted to point is for Tanvi, we use a cutoff of 470 at our center. In some cases, we've gone up to 450 also in low myopias. And the other thing I would say is that in high myopias, because of epithelial hyperplasia that sets in, we tend to get, use, as sir said, using of steroids for a longer time. It helps. Because of epithelial hyperplasia, patients tend to have some induced refractive error and they are not very happy sometimes. And we just continue the steroids, lubricants, and we reassure them we don't have to do retreatments. And by 3 months, they usually settle. And for that reason, for higher myopias, you tend to have slightly longer duration. But again, for high myopias, we use a slightly larger transition zone. We smoothen the edges, and we tend to get faster epithelial healing. So that additional point can be done for high myopias. Thank you.
So Praveen, if I can ask you, the summary is that PRK on the one hand is higher safety, no flap complications, less risk of ectasia, whereas the wow effect of LASIK generally we don't see with PRK, and there is a risk of haze. So today, if some patient comes, whom are you likely to advise for LASIK over PRK, or is there no category which you would recommend either LASIK or SMILE over a PRK, or your standard to go is first PRK and otherwise these two categories?
We have 2 femtosecond lasers and we have Visumax as well. So if I advise everybody who comes in PRK, then I think that's not great business sense, right? So in fact, everybody who comes in and is completely suitable for LASIK, if they ask for LASIK, we do LASIK. We don't dissuade them from undergoing LASIK because, I mean, that's how it works, right? It's only that if I have any hint of doubt that this is a cornea that either is not normal, somebody who's really young or borderline, then I always plunge for PRK. But if a patient puts me on the spot and says, if this was your eye, what would you do? And then I say I would do PRK.
Okay.
Yeah.
So just one follow-up question. This, I mean, me included, I mean, a lot of people, I think that cutoff is -4 and, you know, anything more, they will say that, look, we can do a PRK, but be prepared for haze or, you know, certain complications in the future. That is totally out of the picture from what I understand from you.
It can't be totally out, but how many cataract patients do you speak about endophthalmitis? We don't, right? So,
Yeah.
The flying spot laser has made a huge difference.
Okay, thanks.
thank you.
So thank you everyone for your time, and it was a great session with you. And have a nice day. Thank you so much.